Hello, I'm going to present on patient Miss Wells, a 28-year-old African-American female with a history of asthma diagnosed at age 2.5. Miss Wells reports worsening symptoms triggered by cat exposure 2 days ago at her cousin's house. Symptoms included shortness of breath 8 out of 10 and wheezing 6 out of 10, lasting about 5 minutes. Her symptoms worsened with lying flat and movement, accompanied by a non-productive cough. She used albuterol she had at home with some relief, although her symptoms did not completely resolve. Since the exposure, she's had about 10 episodes of wheezing with shortness of breath, occurring about every 4 hours. She awakens with nighttime shortness of breath twice a night. She complains that her current symptoms are beginning to interfere with her daily activities, and she's concerned that her albuterol inhaler seems to be less effective. Her last episode of shortness of breath was this morning before coming to the clinic. She does state her breathing is currently normalized. In the past, she's been hospitalized 5 times for asthma, the last hospitalization at age 16. She has never been intubated. She denies current drug, alcohol, tobacco use. She did previously smoke marijuana for about 5-6 years, but not currently. Stopped at the age of 21. She denies other environmental or irritant exposures near her job or home. No recent spirometry use, no peak flow meter, no nebulizers or vaporizers at home. This patient is alert and oriented, sitting upright on exam table. She's maintaining eye contact throughout the interview and examination and appears in no acute distress. Her oxygen saturation is 97%. An in-office spirometry was completed and showed an FVC of 3.91 liters and FEV1 FVC ratio of 80.56%. On examination, her chest expansion was symmetrical with normal respirations, normal fremitus symmetrical bilaterally, chest resonant to percussion and no dullness, bilateral expiratory wheezes in posterior lower lobes, bilateral muffled words, in the lower lobes, no crackles. So Miss Wells presents with uncontrolled, moderate, persistent asthma following an exposure to a potential allergen and near asthma attack 2 days ago. Based on GINA recommendations, we will start Miss Wells on a low-dose inhaled corticosteroid and long-acting beta-agonist combination inhaler, such as budesonide formoterol. The patient will be educated on other environmental and asthma triggers, including cat dander and smoking. Recommendations will be for the patient to follow up with an allergist and pulmonologist, since she has not previously seen a health provider for these issues. They may recommend testing such as allergy testing and spirometry, although they may see the need for other tests as well. Patient should be reassessed about 2 weeks after starting the new inhaler to evaluate and adjust the medications as needed.